I'm Sheliza, one of the PGY3s in internal medicine. I'll be speaking about an educational framework to decision-making around discharge from ambulatory internal medicine clinics. My supervisors are Drs. Lindsay Melvin and Rodrigo Cavalcanti. There has been an increasing drive to incorporate clinics and internal medicine residency training. An important subcompetency of this is how we discharge patients from the internal medicine clinic to their primary care providers. We sought to understand how staff physicians make these decisions so we can better understand how to teach residents about this. We conducted qualitative interviews and purposefully sampled general internists. We conducted 23 semi-structured interviews across 6 academic hospitals in Toronto. Consistent with constructivist grounded theory, we used an iterative process and constant comparative analysis until we reached thematic saturation. One major theme that internists identified as implicating discharge from clinic is diagnostic closure. This meant that internists may follow patients with undifferentiated symptoms until their symptoms are stable or a diagnosis declares itself. This also refers to following patients who are quasi-stable, who may have frequent exacerbations of a chronic disease. Discharge always involves a conversation with the patient and keeping an open door policy so that patients and care providers can reconnect in the future. Accessibility was an essential theme, which includes patients' accessibility to primary care. Further, internists have access to resources and urgent diagnostic testing and can serve as a bridge to care prior to patients being seen by subspecialists. Individual physician factors such as level of risk tolerance, level of experience in the ambulatory setting, self-identified scope, and gestalt influence discharge from clinic. Structures and models of care weigh into this decision-making. For instance, physicians practicing in a block versus longitudinal model or having access to a longitudinal clinic may determine how long a patient is followed for. Patient factors such as social determinants of health, cognitive impairment, frailty, and vulnerability were identified as factors that guide transitions of care. Teaching around discharge in the ambulatory setting takes place via 3 different ways: teaching via the Socratic approach, teaching via role modeling, and experience as a teacher. The critical elements that influence general internists' discharge practices from clinics include patient, physician, and systems-related factors, and are all centered around the value added to patient care. Trainee education is often informal and occurs via role modeling or supporting trainee independent decision-making under guidance. Limitations to our study include that this is relevant to internal medicine practice in the Canadian context, and it is reflective of ambulatory practice at 6 academic hospitals, but not across all sites. It captures a subset of internal medicine clinics, such as longitudinal or rapid referral clinics, but may not fully capture the spectrum of all clinics. Patients and family physician viewpoints were not included in this analysis. We propose that these elements can be synthesized into a framework for educating trainees regarding transitions of care decisions in ambulatory internal medicine. Thank you.